to Lab 2, and today in Lab we're going to be learning about ECG, and the purpose of the lab is to learn how to conduct and interpret a 12-lead ECG. And an ECG measures the electrical activity of the heart, and it's an important tool for physicians and other healthcare providers. Now, to conduct a 12-lead ECG, you need to place 10 electrodes on the torso of each participant. And when you hear the word lead, you can think of view of the heart, okay? So with 10 electrodes, we can get 12 different views of the heart. Now the 10 electrodes are broken down into two categories, 4 limb electrodes and 6 chest electrodes. And the placement of these electrodes are important, and we're going to go through exactly where to place these electrodes, but first it's important to note that when you're here in lab doing a 12-lead ECG, this is a lab for a learning experience, and we are not trained professionals. So if there's any concerns with the ECG that you get, please consult a physician and go forward from there. So first, let's go through the placement of the electrodes, and then we'll go over exactly how to interpret the ECG. Now, first we'll show the placement of the 4 limb electrodes. Okay, and the electrodes are placed on the right shoulder, and we got our friend Bob here to help us out. The left shoulder, and it's the left and right shoulder of the person, okay? Not the person putting the electrodes on. And the left hip, and also the right hip, which is also known as the ground electrode. Okay, and these electrodes form what is known as the Einthoven's triangle. Okay, and the formation of these electrodes make 6 chest leads, or 6 views of the heart. Okay, and these 6 views of the heart can be broken down into bipolar or unipolar. Okay, and bipolar leads determine the voltage difference between 2 electrodes. Okay, and in this example, a direct line between the right arm and the left arm is lead 1. Okay, and a direct line between the right arm and the left leg is lead 2. And then the left arm and the left leg create limb lead 3. Okay, so these are the first 3 different views of the heart. Okay, and it's important to note that the direction of flow is always negative to positive. Okay, so the right arm is always negative, and the left leg is always positive. So those are bipolar leads. Okay, they create 3 different views of the heart. Now the unipolar leads create 3 more different views of the heart. And unipolar leads determine the voltage difference between the indifferent point, which is a point of no actual electrode that's in the middle of the 3 existing electrodes. Okay, exactly where Will's pointed. And this is demonstrated as an indifferent point to the right arm. Okay, the indifferent point to the right arm creates a view of the heart. The indifferent point to the left arm creates another view of the heart, and the indifferent point to the left leg, okay, creates our 6th view of the heart. Okay, so now with the bipolar leads and the unipolar leads, we now have our 6 first views of the heart. Okay, so now we're going to show the placement of the 6 chest electrodes. Okay, and these 6 chest electrodes are going to create another 6 views of the heart, which is going to lead to our 12-lead ECG. Okay, so it's easiest to place the electrodes on the chest in order of 1, 2, 4, and 6, and then place 3 and 5 after to fill the gaps. Okay, and anatomical landmarks that are used to place V1 and V2 are the 4th intercostal space, okay, on the right side of the participant. So find the 4th intercostal space on your participant and place the electrode on the right side of the sternum. Okay. V2 is in the 4th intercostal space on the left side of the sternum. Okay, so now we have V1 and V2. Like I said, we're going to skip V3, and V4. The easiest way to find it is go on the nipple line to the 5th intercostal space. Okay, so the nipple line down to the 5th intercostal space and place V4 there. Okay, V5 is again in the 5th intercostal space going to the side of the body. And the 6th electrode is again the same intercostal space, but just underneath the armpit. So now we have V1, V2, 4, 5, and 6. and now we'll place V3 directly in between V2 and V4. So these electrodes measure the electrical activity of the heart in the horizontal plane, okay? So the horizontal plane means directly, as Will is showing, on that plane, okay? So the first 6 views that we talked about before on the collarbone, those really view the heart in the transverse plane, okay? And the 6 chest electrodes create views in the horizontal plane. So now that we've gone through the placement of electrodes and you've gotten your ECG tracing, let's go through some of the interpretation of the ECG. And when interpreting an ECG, we have 6 categories to consider. What is the rate, the rhythm, axis, rotation, hypertrophy, and infarction. And let's go through each one of these. The first one, like I said, is rate. Okay, and you guys have at least done this yourselves at one time, and it's really determined the heart rate, and it's useful to help when identify if there's any abnormalities that exist in the categories that we will further evaluate. And when you interpret rate, we use lead 2 on your ECG tracing. And the best way to do this is count the number of squares between beats. Okay? A big box is 0.2 seconds, and a small box within the big box is 0.04 seconds. Okay? So you can count up those seconds between each beat, and you can get rate. Each big box is also 5 millimeters. Okay? So if we assume a tape speed of 25 millimeters a second, we can apply the following equation to calculate heart rate. So that was rate. Next is rhythm. Okay? And rhythm is used to determine if the electrical pacing of the heart is normal. As the heart is generally paced via the SA node, there's conditions where rhythm can be abnormal, and this is referred to as an arrhythmia and can represent some pathological condition. And to assess rhythm, we can use lead 2 again on the output. And questions to ask when assessing rhythm is, well, 1, is the QRS complex evenly spaced? 2, are P waves present before all QRS complexes? And 3, calculate the distance for the PR intervals, QRS complex, and all the other intervals. And your lab manual and class notes have very important details in identifying what abnormalities can be defined from an assessment of these variables. So next is axis. Okay, and axis is really how the heart is rotated in the transverse plane. So by looking to see where the sum of the electrical activity of the heart is, we can tell, well, what is the axis of the heart in that specific plane. And in situations where axis deviates from normal, the anatomical location of the heart may be different or pathology may exist. Okay, and to assess axis, we use the 6 limb leads on our ECG output. Okay, and there's two ways to assess axis. And option 1 is the quadrant method, which is less precise. And you use lead 1 and lead AVF to determine the quadrant that the axis is in. If it's positive or negative, use a diagram in the lab manual to determine the correct location. Okay, the second option is to find the most isoelectric point. And it's important to know, well, what is isoelectric? And it means the deflection of the electrical trace is equally positive and negative. So what you do is you find the most isoelectric limb lead, and the axis is perpendicular to this lead on the diagram in your lab manual. And for rotation, which is really the same thing as axis, but looking at it in the horizontal plane, we again find the most isoelectric lead and use the diagram in the lab manual to identify the exact rotation.
All right, so for the next aspect of interpreting the ECG trace, we'll be looking at hypertrophy. So atrial hypertrophy, when you look at that, you want to look at the P wave. So normally your P wave looks like that, and then it's followed by QRS complex and a T wave. And when you look at that, normally there's just one hump, but in a situation of atrial hypertrophy, what you might see is that there's now this biphasic P wave. And depending on whether the first portion or the second portion is larger. So maybe if the first portion goes up like this, well then the first portion is larger than the second portion, and that would mean that you have right atrial hypertrophy. So for ventricular hypertrophy, it's a little bit different. So in this case, what you want to do is you want to use the chest leads. So you want to use V1 through V6, and what you want to do is you want to look and see whether the progression of those QRS complexes is increasing. So normally what happens is you'll get V1 to V6 progressing normally. In a situation where V1 might be very large and V6 might be very small, then your progression is reversed, and that would be right ventricular hypertrophy. And then for left ventricle hypertrophy, what you'll do is you'll get this trace again, and what you have to do is you have to calculate the height of the S wave in V1. So for V1 is actually, it will be a negative. So again, so QRS, so you calculate this portion, let's say it's 10, but it will be lower like this. And then you calculate the height of the R wave in V5, so you calculate this segment, and if that's greater than 35 millimeters, you might have left ventricle hypertrophy in your ECG trace. So again, we can go through that in more detail when we actually get into the lab, and there's a good example in your lab manual. So now for the last part that we have to look at when we're considering interpretation of an ECG is infarction. And so an infarction is an issue in the blood supply of the heart. And it can either be current or it can be a chronic type of infarction. And so what's often done clinically is the ECG is used in conjunction with other tests such as blood markers or patient reporting. So when we're looking at infarction, one of the common types of infarction that we see is an ST segment elevation. And so normally what you can see is, so again this is the QRS complex, and then it comes up into the T wave. So normally this ST segment is flat, but in a situation of an ST segment elevated myocardial infarction, this will come up by this, and it might return to baseline eventually. So you'll see that this portion here is elevated above the baseline. And then the other aspect you can look is you can look at the Q wave. So normally what you have is a very small Q wave, but maybe in an ECG trace that you're presented with, it goes quite a bit down like this, and that looks abnormal from what you're used to seeing. Well, that may be a sign of infarction, and depending in what lead of the ECG it's in, that could be either anterior, lateral, inferior, posterior. So you can get a little bit of information as to where the infarction may be.